Welcome to NeuroNights. NeuroNights is for anyone who wants to learn more about brain injury survivors, research, and clinical care. Thank you and enjoy the episode.
Welcome to NeuroNights. My name is Kedar Hiremath, and I'm here with Jain and Emily Pateras to talk about music therapy, speech therapy, and more in particular, melodic intonation therapy. Okay, so Anurati, we'll start with you. So just tell us a little bit about what you do and what your training is.
I'm currently a board-certified music therapist at the Cleveland Clinic Children's Hospital for Rehabilitation. I've been there for almost 4 years now, but I've been board-certified for almost 10 years. And I've worked in a lot of different settings. I've worked in hospice and mostly with people with developmental disabilities. And at the Children's Rehab Hospital, I get to work on 3 inpatient teams. So one is a pain rehabilitation team. We have a rehab team, which is brain and spinal cord injury patients, whether it's acquired or traumatic. And then we also have a PEDS team, which is medically complex patients that are usually on trach and vent or have NAS, like little babies that have neonatal abstinence syndrome. And then I also see a dialysis patient usually and constraint-induced movement therapy patients also. Those are 2 outpatient programs that we have. For becoming a music therapist, I studied at Baldwin-Wallace University for 4 years of undergrad. So I did a Bachelor of Music in Music Therapy plus an internship. So I did my internship in New York City. Then I decided to also get a master's degree, even though that's not a requirement to be a music therapist.
That is a wide range of different types of people to be working with and sort of different stages of health.
Yeah.
Very interesting. All right. And Emily.
Definitely. Hi. So I'm Emily Pateras. I'm a speech-language pathologist. I work at the Cleveland Clinic Children's Hospital for Rehabilitation with CCC-SLP. So I primarily work on the rehabilitation team. So it's an inpatient program. We do have a day treatment program as well. And I will see some patients as outpatients as well. But primarily, I'm focusing in on the inpatient rehab team. And like Anurati already said, we work with patients with brain injuries, spinal cord injuries, strokes, all types of neurological deficits. I graduated also from Baldwin-Wallace University, so we are Yellow Jackets, and I stayed there for my master's program. So I have been a speech therapist for almost a decade now, and actually a couple years ago, I studied to become a certified brain injury specialist. So I hold that title as well, and then in addition to that, I'm also on the board for the Brain Injury Association of Ohio.
Wonderful. Okay. So I want to kind of dive into different parts of this because, there's music therapy, there's speech therapy. Speech therapy goes into quite a lot of different things. So I wanted to kind of define that one first.
Absolutely.
It's more common than music therapy, but also music therapy is kind of a big thing in Ohio. There's a lot of music therapy schools and training programs. We just started one up here at Ohio State. And so I want to get into that piece of it as well. But Emily, can you just tell us a little bit about what is speech and language pathology?
Yes.
That's a pretty heavy title. So what do you do?
I think there's actually a joke within the speech community that there's not enough room on our name tags for speech and swallowing and cognition and hearing. So I think the easiest way to define speech therapy is ASHA, our American Speech, Language, and Hearing Association, has something called the Big 9. So within those 9 categories, we're looking at articulation, so that's how speech sounds, language, expressive language, and receptive language, so understanding language, communicating language. There is voice, so our ability to produce sounds and use our voice. There's swallowing, so our ability to swallow and eat in an efficient way that maintains our hydration and nutrition safely. There is also AAC, augmentative and alternative communication. Social pragmatic, there is fluency, there is literacy, cognitive communication. So our ability to express ourselves in a way. So we have to keep the speech part in mind. Our speech language communication is all about communicating and interacting with people. But when we think about cognitive communication, we're also thinking about executive functions to be successful to do that. So our ability to maintain focus, our ability to remember things and recall what we're even talking about. So that memory component is a really big part of speech therapy and executive functions. I think executive functions could be an entire other podcast topic
totally
because it is huge. And I think, too, something unique about speech therapy is we do collaborate a lot because everybody communicates. Every discipline communicates with their patients. Physical therapy, occupational therapy, music therapy, art therapy. Communication is such a human thing. So it's a really important thing for people to be able to do. So being a speech therapist and supporting that is really special. But that executive functioning piece is shared throughout occupational therapy, speech therapy, and we're all just using it to try to communicate better.
I mean, as you touch on that, right? So the communication in and of itself, I think about it in terms of a social context, right? But also, this idea of patients being able to express what is going on with them. How are they feeling about this very different experience that they're having as potentially a first brain injury or something like that, right? It's a novel experience, and there really aren't a lot of ways for us to know what's going on with that person other than what they can communicate to us. And so I think that's where music therapy has its place, right? It is a way of communicating in some sense. So how do you approach music when it comes to this idea of speech and language or communication?
So with music, I can relate to patients, especially on their preferred music. So it could be any songs they listen to, any genres they listen to, and I would learn those, either how to play them on the guitar, or we might sing them together, or we might listen to it and talk about the songs. Patients that come in with not really much language or speech, they can either use communication devices that the speech therapist would work with them on, and then we could also slowly work on specific syllables to work on speech sounds through songs, like a song that repeats a certain syllable, like "Hey Jude," like "na na na." So that syllable, we can just repeat that and get the brain to train into using the speech sound through music. And music is a motivating factor too. So that also helps in allowing patients to just start singing. Sometimes they might even hum if they're not able to say words. And usually, we'll talk more about melodic intonation therapy, but other approaches also will slowly get the patients to start singing those words and regaining the speech. So music plays a huge role, and music is inherently connected with language. It's been around for centuries, and that's how people have communicated with each other.
It's sort of common to many people, right? Many cultures, right? We all think about music in different ways, but there's fairly common threads. It's very old,
yes,
as a concept for humans. But also what I really enjoy thinking about is, in a therapeutic sense, what does it do to the body? What does it do to sort of, a person's mood? And in these inpatient settings, right, mood can be a really challenging thing to maintain. How does that affect people in different states of recovery, different types of conditions?
I think with music, people are just easily able to connect. Some patients that I work with will suddenly show a brighten effect if I am using their favorite songs to play with them, and they'll just start automatically playing instruments because they're just so engaged in listening to the song that they really like. And sometimes they might just start singing along without me even asking. So I feel like it can connect us on many different levels.
I think I have a bit of a reflection, not spoken as a music therapist, but just as somebody who outside of work loves music. I adore listening to music and participating in any sort of art form involving music, going to see musicals and enjoying concerts. But I think I really resonate with you saying that motivational factor. People really lighten up and brighten their affect. If you are like, oh, I know that musical artist too, let's listen to it together. And then it's so interesting to see, even if they're minimally engaged with you or minimally verbal, like if they're not expressing as they once were, music brings out in them something that they remember from the past. I mean, I don't know if you guys experience this, but there's, a song that I haven't heard in, 15 years. And all of a sudden I hear it on the radio and I'm like, I know every single lyric to this song. And it immediately brightens my mood.
Yeah. And I've seen that with older patients with Alzheimer's, where it's a song they used to constantly listen to in their younger years, like teenage years or in their 20s. And when they listen to the song, they might suddenly start singing along, but they might not remember other things if you just ask them a question with just speech without music. So
it is, I think, a source of frustration for me sometimes that I can remember nothing about my day, but the lyrics in the right context come back. And if you asked me to just say them out loud, I couldn't do it. Correct. I needed the music too.
Right.
So there's just these interesting intricacies about how we engage with music in our minds. It's really cool. Let's think about settings for a second. So, as you're talking about this, right, there's a lot of different kinds of diagnoses. And so then potentially, you're getting care in different kinds of places, right? And Emily, for you, you're working in an inpatient facility, right? But at the same time, speech therapy happens in a lot of different places. What kinds of settings do you feel like are typical for a speech and language pathologist to work in?
Absolutely. Speech therapists are in the schools, they're in outpatient clinics, they're in inpatient rehab, they're in inpatient acute level, nursing homes, and hospice as well. So it really just depends on what that patient needs, and then the speech therapist will provide whatever the patient needs.
And how often is music a part of what the speech therapist is doing?
That is an excellent question. Yeah. So I always take music with my older population. It's a preference thing. I'm not trying to fit a square peg into a round hole. If I have this teenager that's like, I only like sports, I never listen to music, I absolutely don't even want to listen to it. I'm not going to try to force it. Yeah. As the music therapist, you might be like, let's be creative and look at a different way to go about it. But it's a preference thing. And I think that goes into that social pragmatics aspect of speech and language as well. Like, I want to motivate them. I want to meet them where they're at. So I'm not trying to force music upon people that maybe aren't interested in it. However, I will say with the young population, I use music in nearly every single session that I have with a younger patient, especially when they're in that phase of acquiring language. I usually set up a greeting song, so like a hello song, and then a goodbye song. So you get a routine built in. And with pairing it with the music, you're hoping that that patient will then remember, oh yeah, in that goodbye song, we do these movements and then I wave goodbye. And then there you go. Waving means something. So you're pairing it with the music, and all of a sudden, even if that patient maybe wasn't waving before, you're kind of using that as a tool to develop their language.
It's almost like there's an accessibility to it that enables some of these other things.
When you come to the rehab hospital, you have some pretty strict CARF guidelines to go by, where you need to meet a requirement of hours per day, hours per week, in order to be deemed a rehab program. So those strict hours are for occupational therapy, physical therapy, and speech therapy, and usually we divide that up however is appropriate for the patient. But then we get into this human aspect of, we have recreational therapy, which isn't included in those rehab CARF guidelines for hours, but means so much to the patient. Same thing with art therapy, same thing with music therapy, really just trying to make their stay more comfortable and then therefore more motivating, and then hopefully decreasing their length of stay, getting them back closer to their baseline.
No, that's really interesting to think about it from the health services side of thing, right? And why is that maybe a good business decision?
There can also be like contraindications to using music therapy. Okay. I'm trying to think of examples. I think in hospice, I had a patient who came in with musical experience and they were a performer. But I think just not being able to do that would increase their anxiety.
Sure.
In like seeing somebody else do it and not being able to engage in it themselves. So then it became like, okay, maybe we don't want to work with this patient.
It's more of a
because
pain point for that person then.
Yeah.
So is it fair to say that you're thinking about the motivation that music type provides, and also maybe what that type of music can do for a person, in that like maybe they need calm or maybe they need stimulation?
Yeah. We also use music entrainment. There's this idea called ISO principle, a technique, and where we can match the patient's heart rate or their affect, and kind of like, say a patient is really anxious at that time, or they are just presenting really high heart rate. We can slowly help bring it down by like matching the heart rate, matching their affect, and then finding songs that are still in the preferred genre, but slowly, gradually decreasing the tempo of the songs. So starting with a faster song and then going with a less fast and then slowing down and then a really slow song. And that can really help decrease the anxiety and train the body and the mind to just kind of relax.
Yeah, it's nice to have sort of an external thing that helps you to find that de-stressing, right?
Yeah.
Because otherwise it's a pretty hard thing to just say, well, I'll stress less.
Yeah.
Are there genres that generally work better? Are there sort of...
Honestly, we can work with any genre. It's very individualized and patient preferred. So it really depends on what the patients enjoy listening to. If the patient is not able to communicate those preferences, their families might be able to. If nothing else, we kind of look at, the age range they're in, their backgrounds, and their cultural backgrounds, and what all might work. And depending on that, we might try different kinds of songs, different music, and see if the patient responds to anything.
Oh, for sure.
Yeah. What about you? So in terms of, what aspects of music do you think really work well for the types of goals that you would have for your patients?
Such a great question. I do have 3 genres and 3 ideas to go off of with that, but I do want to add on to your comment. So Anurati and I do a lot of co-treatments when it's appropriate for the patient, obviously. Sometimes patients really benefit from having music therapy, recreational therapy separate from their main 3 billing providers, because we want to try to build up their day and increase their cognitive endurance. But sometimes patients can't tolerate that, and we need them to join those main 3 therapy sessions. So then that way they aren't, working as much. But we just a couple days ago were co-treating this patient, and he was having a hard time with taking his medicine. He was not happy about that, and he needed a lot of, I think, just regulation. This is a patient with a brain injury, and he was in a stressful situation of having to take his yucky tasting medicine. So, we went in, he took his medicine, we redirected him with playing some music and kind of giving him his own space. But the specific song that Anurati so masterfully chose was Rainbow Connection, by Kermit the Frog. And I can't think of a more calming song than that. And it's important, I think, to see what the patient needs in that moment. And if they're like slow moving, they're exhausted, maybe they need to pick me up. I think we're going to pick something that's a little bit more upbeat. Or if they just had a hard time taking their medicine, maybe we need some Kermit the Frog sitting on a log in our lives. I just thought, like, when you were talking, I was like, oh my gosh, we just did this. I think talking about co-treatments is a whole other topic that we could even talk about today. But going back to your question specifically about what genres am I using for specific goals, I have 3 examples for that. So I think if a patient is having a really difficult time with word finding and naming, I'm going to resort back to what we call as automatic speech. So sometimes that's counting, sometimes that's the alphabet. It's familiar things that you say without even thinking. So that could be singing happy birthday. I think we all have happy birthday ingrained into our memory. It could be singing a nursery rhyme. So that might not be a preferred song. I don't think happy birthday is anybody's favorite song. However, it's familiar and it's known. So even if it's not their favorite song, if a patient is having a hard time with communicating and all of a sudden, wait a minute, I can say these words because this music brought it out, even if it's not their favorite thing, then they're all of a sudden motivated because they have like that immediate positive feedback. The other two genres may be a reflection on myself, but I am a big fan of musical theater, but specifically for projecting your voice. And like if I have a patient that is working on respiratory strength and endurance or vocal like volume of their voice, now I don't thrust this upon them and say you have to sing musical theater numbers, but sometimes they are motivated by that and they maybe came from either a choir. We've had patients like that before that were performing in their school, their high school, and they were competing in their cantorum. So using big belting numbers in musical theater is such a great exercise and it's motivating. So that's, I think, the second genre that I sometimes probe just to see if it's something they're interested in. And then the last and most motivating, and specifically for pacing for speech and working on respiratory strength and endurance, is rap and R&B. And something that I like to do too, this is a little tip for a new speech therapist that maybe don't know about this, but on YouTube, you can go to any video and slow it down. So sometimes you'll have a specific rap, a section in a rap song that is pretty fast. And the patient knows it, but they just cannot keep up from a motor planning standpoint. They can't get their mouth to move in that way that fast. So what I do is I go on YouTube and just decrease the speed. So then that way we can still work on saying it with a slower pace. I might also incorporate a metronome to get the pacing involved as well. Again, it's preference specific. You know, if they are a classic rock person, I'm not going to pull out the rapping. But if I don't have anything to go off of and I have specific goals for voice, I'm going to gear towards rapping and R&B, or honestly poetry too. But poetry you can say in a way, and we do this all the time too with books that have a rhythm or a pattern to it, and incorporating the intonation of it that way. With poetry and children's books.
Yeah, I think some of these things, you know, what as you're picking your genres, right? I see, Anurati, why you're picking some of yours, very physiological, right? Mood and emotion as well. And Emily, I think, you know, it does make sense. Like you're working on different aspects of
100%. How
how you can improve your speech. It's interesting to think about how you wield these tools, right? So in particularly in brain injury, right? So we're talking about people who have had these, you know, maybe it's an acquired brain injury or traumatic, and they're in the process of recovering quite a lot, or maybe just specifically their ability to communicate. What kinds of symptoms do you see in those patients, and what kinds of tools do you specifically use for the brain injury survivor?
So I would say as a speech therapist, I'm looking at a lot of different aspects, as I mentioned kind of earlier with the big 9. So specifically with brain injury, I'm making sure that they can functionally communicate and people can understand what they're saying. So those are like the main 2 as far as expressive communication goes. You know, it's obviously everything in our brain is so dependent on the location and the severity of the injury itself. But just for this example, if I have somebody coming in that I know has an expressive aphasia, maybe they have Broca's aphasia. So aphasia just means that you have difficulty expressing yourself in either expressing yourself or understanding. And there is an aphasia diagnosis tree that looks at their ability to answer simple questions, to be able to repeat after you, being able to follow directions. And based off of how they respond to that, it kind of gives you your diagnosis of aphasia. But in the general sense, we're looking at expressive aphasia, meaning they're having a hard time expressing themselves, and receptive aphasia, meaning they're having a hard time understanding. Now, sometimes they could have a global aphasia where both are difficult. Another thing that we look at with the aphasia tree is their fluency. How easy is speech to get out? So Broca's aphasia specifically references the area in the brain, the Broca's area. So if there's a stroke or a brain injury, a trauma of any sort, specifically in that part of the brain, they're likely to present with Broca's aphasia, which is an expressive aphasia. One of the approaches specifically with expressive Broca's aphasia is melodic intonation therapy. So that is absolutely a tool that's in my toolbox for treating brain injured patients.
With melodic intonation therapy, we both use it very similarly, speech and music therapy, where you're working on asking a question to the patient and they are going to respond to this question. But you ask this question in a way where the pitches of the different words kind of go up, like according to the question. And you're tapping their left hand at like a very consistent tempo. And you are asking this question, like, what is your name? Something like that. Yeah. And that helps to like activate that side of the brain, but it also is using music to help activate that side of the brain. So you're providing that like physical input, but also the auditory cues.
I want to kind of dig into that.
Yes.
So you're tapping their left hand.
Yes.
Right. Okay. So then that's gonna activate the right side of their brain. Yes. Music is sort of on the right side, right? As we kind of think about this, arts versus logic kind of split, right? And so, so you're activating physiologically, you're doing it through their hearing, and you're modulating both tempo, so the rate, and then also the pitch.
Yeah.
That's a lot of things going on.
Yeah. The tempo is usually consistent. Though.
Yeah, and it's usually a paced process. I think kind of bouncing off of what you were talking about too, if we have Broca's aphasia, so we're talking the Broca's area in the brain is specifically on the left side. And what we like to try to do is play around with some neuroplasticity. We have knowledge that, yes, we have more analytical left side and more artistic, creative right side, but language does still exist on the right side, especially tied to how we have intonation in our voice, our prosody, our music, that more lives on the right side, where maybe our confrontational naming of, I show you a picture of a duck and I say, what is this? Then you have that ability to look at that and say, that is a duck. That's confrontational naming, where we could... And that's more left brain, where now we're kind of hijacking the brain a little bit to stimulate the right side of the brain to then make speech and language a little bit more natural. So you're absolutely right. So it's there in the show notes, there will be an article specifically with the hierarchy of how to present this information. But it starts typically with humming and having a therapist, speech therapist, or music therapist present you with the stimulus, right? So it might be, I love you, which is, and when we're picking those phrases, we're picking things that are important to the patient. And as you're humming it and modeling it, you're tapping that left hand to activate the right side of the brain and give them feedback that way. And then they're going to do it in unison with you. And then as you're doing it in unison, you start with humming, and then you're going to sing it together. And then as you're singing it, choraling, exactly doing it at the same time, the therapist will fade out a little bit. And then all of a sudden, now this person who maybe isn't able to express anything is independently saying something. Independently, as in they're saying the words out of their mouth. They still have the tapping, and they maybe even have the therapist mouthing along, but not saying any words or any sounds. So it's building their motor planning and their processing for producing novel, or important phrases. There is visual cues to give as well, where you write out, I love you, and then you put dots on the board and write the flow. So if it's, I love you, you're putting an arrow up for love and then an arrow down for you. So like starting at the bottom, going up, and then going down. But if a patient, maybe they're learning to read and they can't read, I might not put the words below it. I might just draw it out. So that's where the clinical practice and clinical application kind of comes in. So you're presenting them with the visual feedback. You're presenting them with that tactile tapping. You're presenting them with the auditory cues, and you're doing it with them and slowly fading away. And I think as they get more confident with shorter phrases, the idea is then to move up to more complex phrases, more complex words. And then my favorite part of it is not even giving them the cue of practicing it, fading it away, and then maybe saying, what did you say? So you're tricking the brain. You're not giving them the cues that they're used to see if they can continue to carry it over. Because that's the goal, right, is to carry over anything that we're working on in speech therapy into the real world. So then that way, when they see their mom, they can say that they love their mom. And it's when they're struggling with that.
And so, I mean, so there's a lot in here, and I don't have enough time to ask you all the questions that I'm thinking about. But this sounds like neuromodulation.
Yeah.
You know, and it's just doing it through a cultural practice in some sense, as opposed to a device.
Yeah.
Which is really cool, and I've never thought about it that way. So that's really interesting to me.
Sorry, I was going to add one more thing with music and activating the language part. We can also do like some other techniques to like get up to the level of doing melodic intonation therapy. So in my own sessions, I might first do like music speech stimulation, which is another neurologic music therapy technique. And in that, it would be like giving patients a song that they know and leaving out the last word of the song. So like, you are my, and then cueing them into singing the rest of it. We might use like preferred songs, but also phrases like, what can I say except you're welcome?
There we go.
Yeah, so that they can say those words and practice like saying one word at a time.
Yeah.
And then maybe we would move on to melodic intonation therapy and start working on phrases and longer phrases.
And I just think it's so beautiful having, two different fields. And because speech therapy absolutely has cueing hierarchies for word finding. And, we're incorporating it, and it's similar but different because we will do a lead-in cue, as in the speech therapy world, we'd call it. So I might say, you brush your hair with and then you want to fill it in. And it is again, it's related. And it's just really cool.
So when you do this, right, and as you're kind of progressing a person to be able to do melodic intonation therapy and then to do it itself and then to kind of wean yourself out of that, right, so that they're doing it on their own, do you find that, then people are singing their conversations? Does it stay in the melody, or does the melody kind of fade out and we start to get to just sort of speech as it is?
So I could take that question. I think it depends, which I hate saying that it depends, but I think when we look at treatment for aphasia specifically, we are looking at either a restorative approach where we're trying to restore what's lost, which would be melodic intonation therapy. We're trying to get them to verbally speak again, versus a compensatory strategy like an AAC device or an external communication device. So in this situation, it sounds like, for this patient, we've picked melodic intonation as a good approach, and we want them to generalize that and to become less sing-songy with how they talk. And I think that is absolutely possible. Something that they talk about is actually a similar approach with memory and like executive functions as well, but like a self-talk approach where we're processing everything out loud, and then we're going to maybe whisper it to ourselves and then say it internally. So it's that practice of we're practicing out loud, and then we're maybe going to get a little quieter, and then we're going to try to say it in our head, but then do it in a way where there's a specific German word. It's called sprechen. Sprachen I think it's Sprachen.
Yes, I had this in my mind.
I know. So it is then, as the therapist, you're not just singing it with them, you're transitioning to a spoken song approach. So you as a therapist are then not modeling it singing. You are decreasing down to saying it in like less of a sing-songy way. So there are definitely approaches for melodic intonation therapy to be less singing and more spoken. I think in the cases that I've specifically used this program for, they usually end up taking off pretty nicely. And even sometimes it does sound a little sing-songy, but they're pleased and satisfied because they're able to communicate it. Right. So
Yeah, sure.
And also with the last step of melodic intonation therapy, when we're like, what did you say? They might just answer instead of singing what they said. So like when you're working on the I love you, and they're probably singing I love you, but then at the end, when you're asking them, what did you say? Their brain might automatically convert that into speech. And so that's the whole idea of like giving them strategies to generalize singing into speech.
Awesome. Okay, so in the interest of time, I'm going to give you some lightning round questions.
Love that.
Okay?
Yeah.
So first off, does rhythm matter?
My lightning round answer is yes. And I think really quickly, I know it's lightning round, but we have prosody to our speech. We naturally talk up and down and have a pattern to how we talk. So yes, I think it does matter.
Yeah, definitely.
Okay. So you're doing this in clinical settings typically or professional settings. How would you practice any parts of what we've talked about at home or with a non-professional, right? So maybe a family caregiver or a friend. Is this something that people can do on their own?
Yeah, I think we can give the steps of how melodic intonation therapy should be done, and we can do that in front of caregivers, or we can give them information about this is what we've worked on if they want to practice that at home with their kids. So yeah, definitely.
Yeah. Also, yes, I love homework. I love training caregivers to do the carryover. And then sometimes the homework will also be, hey, in this next week, maybe it's an outpatient that you're not seeing for another week.
Right.
Write down the top 5 things that's important for you guys to talk about. And then next week, we're going to make those into our targets.
Yeah, they can be like specific phrases that they're working on at home to say and request, and we can use that into melodic intonation therapy.
And if someone is not able to access a professional at all, right? So you're training, right, and providing homework. Could they just pick this up? Could they just listen to music and try it out for themselves? Or is there maybe a potential negative to doing that?
I don't think that there's necessarily a negative to doing it. I am more concerned about access. I think if you're at this level of having a severe Broca's aphasia and you're frustrated with your communication, the approach does require some level of receptive language skills to be intact, but I just have I think if you wanted to listen to music and you wanted to use that to kind of guide yourself, but as far as a specific melodic intonation approach, you would need more of a professional guiding you. Yeah. But if you want to make your own program, if it works for you, then absolutely do it.
Yeah. Or if you want to just sing along to songs, like to even just work on speech, hum along and then sing along. I think that could be something people can do on their own.
It's what I do before I have to do public speaking.
Yeah.
Perfect.
Great.
Works out.
Vocal warm-ups.
Yeah.
The last question that I have here is, if you're shopping around for a speech and language pathologist, if you're shopping around for a music therapist, which again, most of the time you're probably not shopping. This is the person that is assigned to you or something. But if you have some sense of like what makes a good fit for a brain injury survivor to work with that kind of professional, what are you looking for as the survivor?
I also really like this question. I think every speech therapist, regardless of their training level, has had in a grad school level information given to them about approaches for aphasia. And within that, melodic intonation was definitely covered. This isn't a very new treatment approach. This has been around for a while now. So I think what cues you into having a good speech therapist is you go into that session and either the caregiver, the person that's taking care of this person with aphasia or the person with aphasia themselves is telling them, hey, I'm really motivated by music. I think this would be right for me. To me, a good speech therapist would be like, yes, absolutely. Let's look into it and let's work together for it. I don't think you need to be an expert in brain injury melodic intonation therapy to do it. I think you need to review, maybe get that old textbook back out from grad school. But I think having a speech therapist that's willing to work with you on what motivates you is the most important thing to work for or look for when you're shopping around.
All right.
Yeah, for music therapy, we actually get training and education on working with many different populations and settings. It might be through doing different clinical settings in school or just like studying about it, having classes that are particularly about physical rehabilitation or mental rehabilitation or for developmental disabilities. And so I had these kind of classes in undergrad. And so I feel like I came in as a young professional with all the knowledge of these different areas. And then I started working with the people and I was able to develop more skills in that. But I feel like most music therapists that are trained, have completed their internship, board certification exam, they are probably capable of doing this and working with anyone. And then for shopping around, it really can be referred by anybody, music therapy. So, and for anyone. So if they find a place, a setting that they see offers music therapy, they're like, this would benefit my child. They can totally look into it. They can refer themselves. They can refer their child. But like with the hospital, anyone can refer the children to us also, like the nurses, the doctors, the speech therapists, any other therapists, really, anyone can refer.
Well, Emily, Anurati, thanks so much for being here today and talking to us about this.
Thank you so much for having us.
Thank you so much for listening to NeuroNights. This effort is sponsored by the Center for Brain Injury Recovery and Discovery at The Ohio State University and is supported by our partners, Buckeyes Raising Awareness in Neuroscience and the Ohio State Wexner Medical Center. Each month, we release a podcast episode about a brain injury topic. We host a virtual live Q&A with our podcast guests, and then we host another virtual session with the brain injury survivors sharing their story. Please find more information about this effort at go.osu.edu/neuronights. Sign up for our emails there and be on the lookout for live Q&A details with our podcast guests. You can find us on Spotify and YouTube to listen to previous episodes. We hope you can join us again next month.